Hello, and we welcome you to our inaugural Surgical Clinics podcast. Although this is our first podcast, Surgical Clinics has published for over 100 years as a bi-monthly publication consisting of review articles devoted to a central topic important to general surgeons. I'm John Vassallo, the managing editor for the series here at Elsevier, and for this first podcast, we will be discussing the February 2022 issue on surgical critical care. Here to discuss topics such as the effects of COVID-19, hemodynamic monitoring in the ICU, non-invasive oxygen and ventilation strategies, and multimodal analgesia will be our consulting editor of Surgical Clinics, Dr. Ron Martin, senior surgeon from the Department of General Surgery at Pullman Regional Hospital and Clinic Network in Pullman, Washington. Joining him will be the guest editor of the Surgical Critical Care issue, Dr. Brett Weibel, Associate Professor of Surgery at the University of Nebraska Medical Center in Omaha, Nebraska. Welcome to both of you, and over to you, Dr. Martin.
Thanks, John, very much. Appreciate the introduction, and thanks for starting us off with our inaugural podcast. After just about 20 years of editing this series now, this is the first time we've gone into this area, so this is an exciting new day for the Surgical Clinics. We're delighted to have Dr. Brett Weibel here, who's been super useful to us at the series and has produced a fantastic collection of articles on critical care. So, Brett, great to have you here this morning and to see you on the link and be able to talk a little bit. Of course, we gave you a nice, easy, tidy, small topic that's simple to cover, like all of intensive care. And on top of that, we threw it in the middle of an unprecedented pandemic. So, as we talked about, there are four sort of articles that we're going to kind of focus on, but we can go wherever you like with this conversation. But let's start off with the article written by our good friend, Dr. PJ Schnartz and his colleagues, that's looking at COVID in the ICU, since that's kind of first and foremost people's mind. I guess my first thing would be is, even though we have a short lag time from when these were written to when these were published, from the time we had this in final production till today's conversation, we've actually had the entire Omicron wave come through, which seems like forever ago, but it really wasn't that long. So overall, where would you say we are now in terms of ICU utilization management and newer concerns, specifically with reference to how much different the Omicron wave was from previous waves?
This is a disease that's been changing rapidly in front of our eyes these last 2 years. Luckily, this wave seems to be, while more infectious, at least less severe with regards to the hospitalizations and the ICU utilization. Luckily so, because I can't imagine having the same virulence as the initial waves. Or the Delta wave that would have been more overwhelming than it actually was. We just got through our peak time here in Nebraska just recently with the Omicron wave, and it still has effects to us. We had to go on to basically emergency standards to get through it. So just this last week we started doing elective cases again. So it's still causing problems. Hopefully we're going to follow the same guide as prior respiratory pandemics, a 2-year cycle before things calm down. But this is not a organism that hasn't reared its head before, and I'm sure it will rear its head again before we're done.
Yeah, how are you holding up on bed space and ventilator space, et cetera?
At the moment, we're doing well. Like I said, we had our peak hospitalizations. We're coming out of the crisis standards to start doing elective. But definitely there's still folks hanging around, but we're still, at least from a supply chain, having the resources, we're managing this wave. So we should be seeing the deaths and discharges coming in the next few weeks. So
in PJ's article, he and his crew go into a bit of time talking about thrombosis and prevention, and there's a lot out there about the different mechanisms of creating hyperthrombotic states. What can you tell our listeners about where we are with that, our understanding, and how best to treat it and prevent it?
That's a good question. I'm not sure we completely know the answer to that question. That's still in the process of being worked out, elucidated. This is not an uncommon process with any of these inflammatory prothrombotic states. Heparinoid type products, with their anti-inflammatory effects as well as the prevention of microthrombi and organ dysfunction have been, important points to all these things. Take ARDS, for example, just the use of heparin alone improves mortality in that state. Again, probably through prevention of microthrombi as well as the anti-inflammatory effects. So, but I think it has a role. The question is, what is the full role? Who should get fully anticoagulated? How much?
And do we know how long after? Should we treat this like regular PE with or without a PE, or do we have a sense of duration yet?
Not that I've seen. I'm sure there's literature out there. This again, so fastly moving. But I haven't seen anything yet directly about the long-term anticoagulation yet. There's probably something buried somewhere out there.
I've been looking. I got some personal interest in this with some family things, and I don't think I'm any further along than you are, despite a deep dive. But I was just testing the water.
I think this is a disease that we're going to be learning about for years as it becomes more endemic and we get annual or biannual infections. I don't think this is going away anytime soon. I just think we're going to get used to it.
Well, let's hope we do learn from it. We haven't always done our best in the past, so we'll see if we can make a change in pattern. So in terms of, let's talk about oxygenation and support. So what do you think there's been obviously some moving targets, but what do you think our best current strategies are for supporting oxygenation and lung protection? And I guess to a lesser degree, assessing ventilation with this, because it seems to be a predominantly oxygenation disease. But what do you think about that?
So definitely, things that we've used in the past with ARDS, like proning and non-invasive ventilation, I think have their role. The non-invasive, I'm not so surprised that it's not really changing the need for intubation, and but it's pushing the ball down down the field a little bit to delay the intubation, especially in a time period where you're scrambling for resources. A few hours more down the road to having a ventilator available might change outcomes. Though, as we know, if you get intubated, the mortality definitely increases with this disease. I think this is just the severity of the problem we're seeing. That the ACE2 receptor, being such a ubiquitous receptor, affects everything in the body. While the lungs tend to take the brunt of it, it has the neurological and the cardiovascular and the GI problems as well. And it's such a vague presentation at times in these asymptomatic or relatively asymptomatic patients. That if this was just a simple, I'm going to get sick and recover and not have these long-term consequences, then, getting a natural infection for immunity might be a reasonable play. But this isn't. This is a disease that can linger, has significant risks of, for parts of the population for ongoing cardiac issues, for example.
Yeah, well, I think, that we're going to get back to the ventilation bit in one of the other chapters, but I think that in looking at your last comment, that's one of the problems on the national level we've had. A lot of the stuff I've been writing in the forwards over the years has been about the dynamic between individualism and collectivism, and where we can actually get people on board with the same message. And we've always hoped that the clinic series provides information that people can rely on so that they can make good decisions. But obviously we're not out to the general public. So, and as you say, it's not just getting sick and getting better. People look at the mortality curves, and there's a fairly low likely chance of dying from this, even in the worst case scenario. But when you look at the massive numbers of people infected, low probabilities still turn into huge collective problems for the country. Where are you guys at with staffing and protection with them, with various measures, and where are you at with vaccines and boosters for your your team, your staff, your nurses, all the people who work there? How are you guys doing with that?
So vaccinations, they've been right out of the bat. The gate. We got vaccinations. So literally the week after that was approved for emergency use, we were getting vaccinated. Predominantly with the frontline workers first, and then the rest of the community, with the healthcare community. Subsequently, we've already gotten boosters as well, and it's pretty much everyone's getting immunized here. That's pretty much the take on it. Personal equipment, isolating these patients into their separate wards. The very basics there are accomplished. Everyone's running around with N95s. I've got a pile of them on my desk right now that we're using. And during the crisis standards, they were required. We weren't even talking about just regular surgical masks. We're talking about N95 use. That's predominantly where we're at. There's still, guidelines in place with the aerosolizing procedures, with making sure the rooms have cleared between intubation and getting the rest of the staff in, as well as extubation. Trying to limit some of the more aerosolizing procedures if possible, using alternative means, but it definitely still large resource use to protect the healthcare group. And that's one of the reasons we went on the crisis standards, is we were having a significant number of folks who were getting infected from Omicron and out at work. So we couldn't continue, work as usual.
Sure. Where do we stand now with the antivirals and the immunotherapy, convalescent sera? How are we managing? I mean, I know that we have some criteria things. Some things are allowed as an outpatient. Some things are not allowed until you're an inpatient. But what can you tell us about that?
Well, definitely, I think our situation is much better than it was a year ago. Omicron, while more infectious, seems to be less virulent. Well, I guess virulent is not the right word. Less efficacious as a disease process. As well as the introduction of the antivirals. Let's see who's got things out. We've got Pfizer with their combination drug that inhibits the enzyme. I can't remember the name of the drug, as well as there's another group that's got the antiviral that inhibits replication now as oral agents to take to try and prevent, as well as the infusion. Again, trying to prevent hospitalization. So I think between immunization and those agents, we definitely have a decreased risk of more severe illness than we did, say, a year ago. But as you're right, you're exactly right. With the degree of number of folks getting infected, even though low probabilities turn into large numbers. And unfortunately, I think the political nature of the conversation has created a bad problem for us. It's amazing that the United States represents a little over 4% of the population of the world, yet we have about a sixth of the deaths. It's just disproportionate.
Yeah, that disturbs on a lot of levels, especially given some of my older jobs working for the federal government. But we won't get into that today. We'll pick a different day for that discussion. Exactly. So let's look at one of the other chapters now. Monitoring. Now that's near and dear to my heart. Because, no pun intended. But when I grew up, I mean, we had so few tools, but we used them well. And as a junior house officer, you were forever putting catheters in people and measuring pressures and doing things and working with the hemodynamic techs and so forth. But
I caught that as well. The Swan-Ganz catheter, the volumetric swans. We're still widely in use when I train. So,
yeah. Well, the thing is if you know what to do with the measurements, you can get a lot done. That seems to me to be the biggest issue that's out there is that not everybody understands what it is they're looking at. But so basically, the chapter from our colleagues here basically looked at current tools, sort of versus point of care ultrasound use. And so I think before we get into the differentiation of those, most of the tools we have focus on some mechanism of how we get blood or something to an organ. But we don't really spend a lot of time looking at, are the organs getting what they need? And that seems to me, so, when we look at, if you look at one vague definition of shock as being inadequate perfusion to support aerobic metabolism, we do a good job of figuring out like what's in the pantry, but we don't do a good job of figuring out, what are the cooks using in the kitchen. So tell us your thoughts on where we are with that these days.
Well, I think we've just switched one thing that we don't understand for another, to some degree. The PA lines, you're exactly right. I remember troubleshooting them as well as, trying to figure out, is this an accurate measurement? They were reliable if you knew what you were doing with them. The problem was, I think, that a lot of people couldn't recognize when it was giving bad information, or sometimes what the information even meant. So they fell out of favor. And, there's a whole generation, I think, of us who learned on PA lines. Those have gone out of favor, and now we're using ultrasound technology largely. And I can tell you, I'm having to pick that one up myself over time, and it's not a panacea either. While yes, seeing is believing. Being able, if you do get good images, you can see the contractility of the heart, and is the pump full? Is it pumping correctly? Is there something obstructing, like effusion around it and tamponade? Yeah, great. When you can't do it, it's not so helpful. I'll give you an example. I was on call earlier this last week. I had two patients code for different reasons, both with extensive subcutaneous emphysema for different reasons. And there are no windows. All you got is the haze from the air reflecting back. So, you have to go back to other methods. Put central lines in them, measuring CVP, and they're watching their response to fluid, doing straight leg raises. Going back to the basics, so to say. I don't think these advanced modalities replace that.
Brett, that's always been my concern too, is most of the other techniques we have tend to do a little bit better. They're a little less operator dependent, and especially in austere environments, ultrasound, it's great when you can get it to work, but when you can't get it to work, you got to have a backup plan. So, thoughts on that topic? Agree or disagree?
I'd have to agree. Especially in austere environments, where you're limited. Definitely, just isolated pressure measurements prove not to be very useful. There are different reasons for why you can get that number. You got to look at it over time and the response to different therapies. And I think that's why people have really transitioned more to these flow directed measurements. And again, but not that they're a panacea either. You look at the things like pulse contour wave analysis. There's certain requirements, like the patient not spontaneously breathing, that you have significant, change in, the preload, through adequate tidal volume changes. The tidal volume is not adequate enough, then you may not be getting the measurements you want. And the false negative rate on a lot of these things can be very high, especially with what I'm doing. I want my patients to be in a lung protective strategy a lot of the time, but I also want them spontaneously breathing. So, both things sort of can make those type of measurements less reliable. I mean, when they're present, but if they're not there, it's like a lot of things in medicine. If you see an abnormality, there's probably an abnormality. If you don't see an abnormality, there still may be an abnormality.
I think historically, my bigger concern has always been is that there's a tendency, particularly amongst junior people, that they want to just get the numbers and see if that gives them the answer.
Oh, they love numbers.
Going on. They love numbers because numbers don't require judgment. But if you think about what's going on with the patient and what you expect to find, finding out if the numbers support your conclusions is usually more likely to get you the right answer.
I would agree. I think there's a transition as people age in their practice to I mean, I'll be the same way. When I was training, it was all about the numbers and trying to figure out what was going on from the numbers, as opposed to looking at the patient and trying to see, okay, what seems to be driving this in general, and then going into specifics, and using the numbers to help guide that from a different direction. So the younger residents, new attendings love their numbers. And I'll be truthful, I've gotten further away from the numbers as I get older and grayer. So,
well, that's the evolution. Once you get into expert level stuff, we know, and if I put on my old hat as a former director of medical education and, program director, you try to get people to the level where they have pattern recognition rather than trying to, be hooked on phonics and look at each individual little piece of information and spell it out. And it takes a long time to build up. But once you develop the mastery, you realize individual numbers aren't as important as you used to think. I don't know how to change that teaching paradigm. I think we're going to be stuck with that for a long, long time.
I probably agree. I mean, I have a similar sort of discussion with the residents. I tell them there's only so many stories that you have to know. You just have to know which variation of the story you're talking about.
That's right. Shakespeare wrote all the plots. All the rest are just variations on the theme. Well, let's talk a little bit, since we're talking about non-invasive things. There was a fascinating chapter in there on non-invasive, ventilation oxygenation strategies. And we talk a little bit about this in the COVID bit, but, so here's one of my general concerns work in a number of different places. So give me your thoughts on, how do we effectively assess oxygenation, ventilation, and what shouldn't we be doing? And let's start there for a moment.
Sure. So I think some of it's going to be clinical as well as numbers. Can't get away from the numbers. Clearly saturation is easy to measure. And for most patients, the vast majority of patients, it's a very easy way to look at oxygenation. That's always the easiest thing, and people like to do what's easy. Ventilation is much more subtle and difficult. Going back to one of the patients that had issues that night, there were some very subtle changes in their mentation. They weren't as awake as they were, which prompted us to get a gas and look at their CO2 and realize, the patient's hypoventilating. The knowing again the stories, that hypoxia leads to agitation, anxiety. Hypoventilation is the nurse's best friend. Those patients never complain.
That's true, and that's not that brings us. We'll probably get to that with the opioid epidemic stuff, but going back to the early days. But let's carry on.
So I think you have to be cognizant of changes in your mentation, especially for ventilation. Clearly, though, when you've got a patient who you can monitor their end-tidal CO2s and whatnot, those may be helpful adjuncts to watch for that. CO2, though, it's much more soluble than oxygen or nitrogen. Moves very rapidly across the lung. So usually, luckily, though, and with regards to surgery, we don't run into that problem so much. It usually is an oxygenation issue. So unfortunately, I think that we see in surgery, these ventilation issues often creep up on us, and people don't recognize them for what they are. And that's what I've always found with my residents, is that it takes them a while to start recognizing that issue. Why is your patient not mentating? You need to be thinking about carbon dioxide as hypercapnia and the amnestic effects of it on the brain.
Yeah. The problem I used to run into a lot, especially with sedated patients on ventilators, was why do you suddenly have twice the ventilation you used to in the same PCO2?
Uh-huh.
I mean, something's got to be driving that. The thing is the vent techs and the respiratory techs, they twiddle the knobs on the vent, and people they just look at the net result and don't try to figure out the process. But I guess if I were going to give somebody advice, it's understand why your patient's on the settings that they're on.
Sure.
And why they're behaving the way they are. So I guess back to our previous conversation is the bigger picture first.
Yeah, gone is the time, again, going back to my residency, before these volume targeted pressure control modes sort of became very popular. Half my job at night was, along with the respiratory therapist, going around and changing the ventilator settings to adjust for compliance changes in the patients, making sure that their ventilation, oxygenation, their tidal volumes and respiratory rates were all reasonable. Nowadays, the residents don't get that same experience. And I think you're right. They miss the forest for the trees. They're just happy that, the CO2 is fine, not recognizing the fact that the support's gone up considerably on the patient. Is this a production issue? Is this an elimination issue? Is there some change in the lungs that's causing a diffusion problem, and they're not troubleshooting the underlying issue until rounds when you point this out to them? Not to say that I was, the best resident ever, because Lord knows that Croce let me know several times of my failings as a resident. So,
the old adage is that, good judgment comes from experience, and experience comes from bad judgment. So we've all been on that curve somewhere in our life, and not to be critical, I think, the lesson is as we put out the issues to the large group with the clinic series, but as we do it, hopefully we do it similar to the way that we teach in our local environments. It's to try to help people get good judgment, learning from people's experience and bad judgment, so that they don't have to keep making the same mistakes we used to make. But let's talk a little bit about, there's been especially with COVID, there's been what seems to me to be a bit of a debate about how far to push non-invasive ventilation strategies versus endotracheal intubation. Some of it to do with protection of the staff, and it's not as clear. And I think Omicron's made it a little different, but also the pharmacologic support to make somebody be able to tolerate being on a vent or being on BiPAP. So, what are your thoughts on those balancing acts?
That's a hard one. There's always that concern about with these potential aerosolization and these more non-invasive ventilator modes. Like I said earlier, I'm not surprised. These non-invasive ventilation modes aren't so great for oxygenation problems with no easy answer. So, it's great for things like CO2 exacerbations associated with things like asthma and other reactive airway disease. It's great for situations where you're trying to delay someone with pulmonary edema while you get the extra fluid out of the lungs and potentially avoid intubation. I've not found it to be very useful for oxygenation problems that you don't have a quick fix for, like ventilation issues or edema. And I find you're basically just pushing the ball down the field a little bit. The problem is that when you do that, are you now having a more emergent intubation and associated kerfuffle and emergency as opposed to a more practiced and less emergent intubation? Definitely in a more controlled setting is preferable. The question is, how far do you push it? The resource utilization component does, I think, have some effect, especially at the very beginning of the pandemic where we were having problems. We were somewhat spared the effects here because we were already in the process of getting ventilators to replace the ones that we had. We didn't get our full order, but some is better than none, and we still have the old ones. So we were somewhat in good position for the pandemic. Also, it helps that Nebraska seems to be seeing these waves later than other parts of the country. So we have a little more time to prepare. I guess there's some advantages to being a flyover state. People don't come to Nebraska, I think, unless you have a reason to come to Nebraska.
Oh, everybody should have a reason to go to Mexico. Let's not kid ourselves.
There's good corn and good steaks here, definitely.
And good people.
And good people.
Good people, no doubt. Well, that kind of segues us a little bit into the last article we're going to chat about, which is multimodal analgesia, which is, again, near and dear to my heart. This is another thinking person's topic, if you ask me. And as we've kind of talked about things earlier in our career, back in the days when everybody was focused on the pain score being 0 for everybody, there were a lot of us that had a lot of concerns back then. And I think over the few decades since then, they're now more broadly shared concerns that we took our eye off of the fact that opioids are incredibly dangerous, both in the short and long haul. But I mean, with the advent of regional and neuraxial block, well, tell us a little bit about your experience with improving that and making it so that people need less narcotic, need less ventilation, or we can move them through the process faster, even get them through the hospitalization faster. So what's your experience with that been like?
So the first thing I would say is if you don't have a acute pain service that is actively providing neuroaxial or peripheral blockade, you need to get one. It makes a huge difference, I think, in the pain management. It is part of our practice. For example, if you were to come in with a hip fracture, the trauma service is seeing you, orthopedics is seeing you, but additionally anesthesia to provide a peripheral block for pain control is seeing you as well. We've adapted a lot of the ERAS thoughts into our pain management, and regional blocks are a huge part of what we do. Large abdominal procedures are getting transabdominal blocks, to the between the obliques, under ultrasound guidance. I think this is that with the invention of long-acting bupivacaine definitely has changed a lot of our practice. And we see reductions in pain scores, reductions in narcotic use. This is just one part of the whole armamentarium with regards to reducing opioid use.
I think we've gone the same way. And, even without ultrasound, you can do a lot of the abdominal blocks. Like if you find yourself doing big laparotomies, you've usually got visualization on the landmarks you need. And with long-acting bupivacaine, works like a charm. I'm certainly with you. And I mean, to a little bit to our previous conversation about ultrasound, certainly image guidance has really helped, at least the anesthesia folk I work with, get into doing very specific blocks as opposed to just epidurals or just spinals, which is, when I was a resident, we had a fairly up and running acute pain management service. And when I went to my fellowship, I went from having epidurals to only having IM narcotic, which was like stepping into the Stone Age for a little bit. I mean, things have corrected since then, thankfully, but our anesthesia colleagues, I think, have really gotten on board and gotten very good with their image guided blocks, not to mention the chronic pain management folk. But
yeah, makes a huge difference. I think it definitely affects how we practice.
Yeah, where are you with the non-steroidals now? Because I get a lot of people that are avoiding them particularly for like in the setting of bowel stuff. And to be honest, I've done several scores of thousands of bowel anastomoses in my life, and almost always use non-steroidals and haven't noticed it to be a problem. But
I love them personally. I think that that non-steroidal use is a huge benefit. When we created our chest wall injury group here, we had a lot of discussions on the multimodal therapies, and Lord knows I was a huge proponent of getting non-steroidal use as part of the regimen and pushing that. Again, some of this stuff goes way back. I can remember discussions with my chairman, Fabian, back in the day when he was discussing his bicycle crash and the rib fractures he had. And he said the only thing that helped was the non-steroidal, that the other stuff basically just covered it up, but it was still a lot of tenderness, and the non-steroidal was the thing that touched it the most. And that comment by him stuck with me. And that's what I've noticed in my practice, that non-steroidal has a huge analgesic effect.
And I might have been late to the game on this one, but what are your thoughts on, the petinoids?
Again, I think they're very helpful. So I mean, I'll just give you what our usual practice is. So people do have narcotics available for their pain control, often as PRNs, depending on the severity of their pain. Tylenol is ubiquitously given outside of, again, contraindication, so severe liver disease. Non-steroidals are included, again, unless there's a contraindication like renal disease or peptic ulcer disease. We often use the gabapentins, Lyrica or gabapentin itself, unless they're older or have some issues with renal dysfunction, the groups that you're worried about the more sedating effects on. We often will use topical lidoderm as well to help with the anesthetic effect. And again, the regional blocks. These are a large part of our armamentarium. Very selective use of muscle relaxants. Pretty much just rib fractures is the only group that we're even routinely considering their use in. But as far as the gabapentins, the pentinoids, we find that they do have at least from our anecdotal experience, they do seem to have a potentiating effect on the narcotic need. That there does seem to be a reduction in those folks. And we do find them useful. But the sedating effects can be an issue, so you have to watch out for those.
I think one of the things we found kind of getting away from the straight neuraxial blocks to the more peripheral blocks is, and maybe we're talking ourselves into something, but a little less concern in the patients whose coagulation status is less clear. Where are you guys standing with the novel oral anticoagulants and how it's affecting your world?
So definitely the anticoagulants with neuroaxial blocks, our anesthesiology colleagues won't even go near them for neuroaxial, but they're very happy to do these more peripheral, like serratus or transabdominal or other regional peripheral blocks. And for a large part, that seems to work well. One of the side effects of having these more regional specific blocks is the less risk of hypotension with vasodilatation. So there's some pluses as well with these more peripheral blocks, but having someone who's comfortable putting them in, again, the ultrasound guidance is a godsend with that. Definitely is useful, but they don't seem to push back on the novel anticoagulants or for these peripheral regional blocks like they do the neuroaxial.
Yeah, and I got to say, I can't blame them. Having sat in enough risk management committee meetings when there's been some question of epidural hematoma or something else, not having the hemodynamic consequences, that's a huge plus. Make it as simple as you can, but not simpler. The old adage. So we kind of covered most of the chapters that we talked about. I mean, what else would you like to tell us? Anything else on your mind that we haven't covered?
Oh, that's an open-ended question. It can only go badly. When you charged me with this simple topic, I know I took
Just for the record, I requested you to tackle it. We did ask you, and you delivered mightily, I might add.
Thank you. I spent probably a week just sort of thinking about how to even approach this, because this is like, being asked, hey, let's talk about surgical oncology, the whole field of surgical oncology. Obviously, there's no way to talk about everything. So, I thought about it and realized there are basically sort of three big groups in my mind. One was the traditional topics, system organ failure, like congestive heart failure and things related to that, or end-stage renal disease. And how do you manage those things? So that is sort of the bread and butter of critical care. Then I thought about topics what has changed considerably since residency to my practice today. And that's where topics like the opioid epidemic and the change on analgesia came from. And then the final thing I thought about is, what are the things that the residents drive me nuts about? Such as non-invasive oxygenation and ventilation strategies. They seem to think exactly in the middle of the night, let me just stick them on BiPAP, because then they'll oxygenate well without any consideration of why are they having issues. This is where topics like the topical coagulant chapter came from. Because you ask the resident, so how does this work? Well, I don't know. Then why are you giving it to your patient if you don't know what it is and how it works? Well, I saw someone else use it. That's not a good answer. So that's where sort of all these chapters came from for different reasons. I think a lot of the things that drove me crazy chapters were also things that I've done, talks on, for grand rounds and whatnot. So I knew the answer I was getting because the people who wrote those chapters either had seen me give those grand rounds or I gave them my grand rounds. So I know what I was getting on those chapters.
We try to put content in context. A lot of content out there, but I think if you don't have people that can review the massive amount of data that's out there and have enough expertise to tell people what makes sense, what do we think makes sense, what doesn't make sense at all, and where should we be looking, you can just get overwhelmed with the amount of information out there. And you've done an excellent job, as have your colleagues, of content into context and giving people stuff that they can read about, understand quickly. I think you've done our community a terrific service with this issue, and we're grateful to you for it.
Well, thank you for those kind words.
Thank you for joining us for our inaugural Surgical Clinics podcast devoted to the February 2022 issue on Surgical Critical Care, Volume 102, Number 1. This series is available for individual print subscription with online access or individual online-only access. Visit www.surgical.theclinics.com to subscribe. The series is also on the Elsevier digital platforms Clinical Key and Science Direct. Be sure to follow us on Twitter @Surgical Clinics, and you can subscribe to the podcast through Apple, Google Play, Spotify, or Stitcher. Thanks for listening.